you very much. I'm very pleased to bring my information to you. This is a wonderful way of bringing information worldwide, and I commend all of you for putting this all together. So I will start. I'll be discussing something that is very important to patients. I think dentists and hygienists have thought of it as important, but patients really want to understand what is the oral systemic link? What is it about the oral cavity that can contribute to overall health? Because they're told that if they floss more, they're going to live longer. If they do things to keep their teeth healthy and their gums and their periodontium healthy, that will contribute to their living longer. But how does that work? So I'm going to demystify it because not only do patients not really understand it, but I think a lot of dental practitioners are not aware of how this all comes together. So we're going to go over this over the next little while. And after you listen to it, you'll be aware, you'll be demystified, and you can explain it to others. And not only that, this will help make people healthy, hopefully worldwide, because I'm getting a worldwide audience right now. And that's why I said, tell your mom you are a real doctor, because so often dentists feel like they are not real doctors, but we can contribute to overall health. So we are real doctors. So the missing link of oral inflammation and, oral systemic health happens to be inflammation, because inflammation is something that is the major contributor to diseases of aging. And we all age, thank goodness. We want to age. Sorry, we may not want to age, but we do want to get older and we want to be healthy as we're older. And most of these diseases start with something going on with the inflammatory response. So let's go into that in greater detail in the local level, and then we'll do it in the systemic level. So periodontal disease is, we know, biofilm-associated inflammatory disease. It's about bacteria. Of course, that's what starts the whole process. But is it only bacteria? What else is going on? It's sort of about the bacteria. That is what starts the cascade response in the oral cavity. So now I will discuss how periodontal inflammation starts, what are the repercussions in the local environment, and then we will go into how that local system can go and be propagated throughout the body and also impact the inflammatory load in other areas of the body. And that's how the link starts. So the story so far, as we understand it, and this story has been known in this way for many years, but sometimes, we go back and forth, bacterial inflammation, bacterial, microbiome, all these different things. So the bacterial stimulus is what starts. Then we have a cascade response. And this is innate and then adaptive. The innate response has to be actively resolved to healthy equilibrium. This is mostly done through the creation of lipoxins and resolvins, and I'll show that in a future slide. So inflammation is affected by multiple risk factors. Of course, we know that, including genetics, because we know that genetics plays a part in everything about our bodies, ourselves. When it's overexpressed, the overexpression of inflammation is a key in the development and progression of the diseases of aging. Treatment of periodontal disease must take into account the inflammatory component as well as the bacterial stimulus. We can't just deal with the bugs. It's not just about the bacterial component. It is very much about the inflammatory component as well. So inflammation is getting a bad rap. Inflammation is very good. Without inflammation, nothing would heal. The beautiful surgery that was just done by the speaker before me. I mean, if we didn't have inflammation, that surgery could not be done. The patient could not be healed and be able to function happily with what he's done for them. So we need inflammation. Inflammation is most definitely beneficial. It's when it goes too far that we have an issue. So what is the innate response? In the healthy periodontium, The inflammation is there to eliminate foreign bodies, and it is protective against injury and infection. If we ever have a trauma or there's infection, inflammation is just up there and goes to improve and heal the area. It is the first part of the sequence is there's vascular dilation. You have more blood to the area. Neutrophils. This is very important. Remember the word neutrophil. These are white blood cells. They are the first responders. And it'll be very important because later on I'm going to go over a possibility of a biomarker to show inflammation in the body, in the oral cavity, and in that way understand if the treatment is working or not. Because the neutrophils are your first responders. Higher number of neutrophils will indicate that there is more inflammation going on and something is happening. Something may be beneficial early on, but also may be detrimental if it goes too far. So as we said, neutrophils are dispatched to the site, then come the macrophages, and then the cytokines. The neutrophils and macrophages give off cytokines. Now, cytokines are those long, things with long names and lots of Greek letters. And then when you see them, you say, okay, I don't know what that is. Cytokines are just messenger cells. They're bioactive protein cell communicators. And they're secreted by the neutrophils and the macrophages. And these are the chemicals that regulate inflammation locally and then systemically. Immune cells and cytokines attempt to destroy, dilute, and wall off the injurious agent to make the patient healthy. So what do we see in all the tissues? I'm going to be showing you in word form what we see in the tissues, and then I'll show it to you graphically in the next slide. So in the periodontal tissues, what we see clinically is more blood, vascular dilation, increased permeability of capillaries, and increased blood flow. So you're going to see inflamed tissue. But and at a cellular level, you're going to see, we won't see it because it's cellular, so you will not see it. But if you did take a look at the cells, you would, what you would see is crevicular fluid, which contains neutrophils, macrophages, and other cells like that. Inflammatory cells that secrete the cytokines that regulate the inflammatory response. On a biochemical level, we have different materials being secreted. Predominantly, you have something called arachidonic acid, and that is released by the neutrophils. Remember, the neutrophils are your first responders. That produces prostaglandin. And we all know that prostaglandin is not a good thing because what it does is it breaks down bone. It does break down bone for a good reason, sometimes early on, but later on it is a problem with breakdown, and then you break down around the periodontal, the periodontium, and the patient will be in much in worse shape. Okay, so let's see what we see graphically. Here we have increased plaque, bacteria. The first responders, the neutrophils are in the area. They're secreting the cytokines. The cytokines are regulators for inflammation. And also the neutrophils are secreting prostaglandins, which in the future, if they stay in the area and they're increased, will start to break down bone. At this point, they're doing other things and not breaking down bone because it's an early stage. The neutrophils secrete the arachidonic acid, and the arachidonic acid produces the prostaglandins. So when we have the active resolution of the acute response, the acute response is good. We have to get things happening, things healing. When they heal, this is good. And this is when we have to have the active resolution. It can't continue. If it continues, that's when you have a problem. The acute resolution is the way to go. So what happens in the active resolution of the acute response? We have the bacteria removed at a cellular level. So that's at the clinical, well, you can't see it clinically either, but I'll show you the clinical response in a moment. At a cellular level, we have crevicular fluid that contains fewer neutrophils, and they're weaker, as well as the macrophages are weaker, and there are remnants of bacteria. At a biochemical level, the arachidonic acid is now not producing the prostaglandins anymore, but it is producing something called lipoxin. And lipoxin is something that is very beneficial in the active resolution of inflammation. Lipoxins are very beneficial, and that they will help stop the inflammatory response when things are totally healed. Also, we all know that everybody's telling us to have more salmon and other uh, edible products to increase our omega-3s, because omega-3s in diets produce resolvins. And resolvins, along with lipoxins, stop and resolve the acute response when things go well and there's no need for the inflammation anymore. These substances help to actively resolve inflammation at the right time when things have improved and the response is no longer needed. So here we see graphically, there are just remnants of bacteria. There are fewer weakened neutrophils. There are weakened macrophages. And the arachidonic acid is creating the lipoxin, which will stop the inflammatory response. And the dietary omega-3s will release resolvins, and that will also help resolve the acute inflammatory response. So this is when things go well. Here we have a healthy, beneficial inflammatory response and a return to health. This is everything proceeds according to plan. The patient starts to brush their teeth and floss and do all those things that we keep telling them to do, keeps everything in order. So if once or twice things are not completely healthy, then the body will come in and fix things. What if it keeps going and the bacteria is still there, the patient's not flossing, there is a prolonged inflammatory response because things are not going well and the body is trying to heal itself, and that is causing more problems than not. So here we have a healthy situation. This is when things do heal. And now I'll show you what happens when things do not. Chronic maladaptive inflammatory response. When the lipoxins are not released, the resolvins are not eaten, the omega-3s are not eaten, and resolvins are not formed, there's still a problem. There are still bacteria in the oral cavity. There's still something happening that is not correct. The patient keeps up with their inflammatory response. It is no longer healthy and beneficial. Now it is chronic and maladaptive. So the burden of pathogens triggers a chronic inflammatory response, releasing these cytokines. As I mentioned, they all have Greek letters. And the chronic inflammatory response drives connective tissue and bone loss. And I will show you how this is done right now. So what is chronic unresolved inflammation? The cellular molecular response to bacterial challenge has a constant feedback and adjustment system. When the feedback shows that things are not resolved, that is when it continues. The neutrophils and macrophages continue to secrete the cytokines. Remember those messenger cells, and they contribute to chronic lesion and periodontal destruction. The cytokines promote the release of something called MMPs, matrix metalloproteinases. And we know most of them as collagenase. There are others, but the most important one in the oral cavity is collagenase. And we know collagen is something that's important all over the body for you, especially in the periodontal ligament. Also, collagenase breaks down collagen in other parts of the body as well. And we know people trying to stay young and healthy sometimes ingest collagen. Collagenase is not good because it breaks down the collagen, and we all want our collagen to keep us young and healthy. So we have collagenase that's breaking down the collagen. Prostaglandins, as I mentioned, is being produced through that arachidonic acid, and here it is now promoting bone resorption. The tissue destruction constantly is adjusted by the host bacterial interaction. The bacteria is still there. The host is still trying to get rid of it, to remove it. And so the inflammatory response becomes chronic, and it's a maladaptive response. So we start off with a deficient host response. That starts off the chronic condition. And then the body goes crazy and it starts being too vigorous. And that is a vigorous host response. So it's the body itself causing the problem because the body was trying to solve it and it didn't stop because the stimulus is still there. So the vigorous host response leads to further tissue breakdown. So here we see more plaque, more bacteria. The neutrophils are secreting the cytokines. The cytokines are promoting the formation of these MMPs like collagenase. The macrophages are still there, munching up the debris. And you can see the prostaglandins are causing the bone to break down. And also, we will soon see the periodontal ligament breaking down. So all this is happening in a chronic response. Later on, more continues. It continues, it's still maladaptive, but it's a late response. And now we have, because the collagen is munching on the periodontal ligament, we now have an apical migration of that's the apical migration of pathogenic bacteria continue, and the collagen breaks down the periodontal ligament because it keeps munching on the periodontal ligament. There are now ulcerations of epithelial lining, and that's when you see bleeding on probing. It gets worse and worse. There's bone resorption that's severe. At a cellular level, we're going to have increased neutrophils, macrophages, etc. At a biochemical level, there will be increased pro-inflammatory cytokine activity. Collagen fragments are very beneficial to the bacteria. They provide nutrition. So the bacteria are very happy. This is a self-fulfilling circle because there are more bacteria because they have more to eat. And it just keeps going and it has to be stopped. It has to be stopped at the early beneficial level. At this point, it gets much more difficult to control. So we see increased plaque, increased bacteria, more cytokines releasing the MMPs, the arachidonic acid, really releasing the prostaglandins, and lots of bone loss, and lots of collagenase breaking down periodontal ligament, which acts as a food source for the bacteria, so it increases the bacterial level as well. So this is what happens locally. How does that contribute to the systemic problems, the diseases of aging? It is a significant contributor to the total inflammatory burden. And that's what the problem is. So we have inflammation in different parts of the body. Obviously, you may have inflammation in the brain area, in the pancreas, which may increase your possibility of having diabetes, in the brain, which may increase your possibility of having Alzheimer's, in the cardiovascular system, in the heart, in the blood vessels, in the liver, in the kidneys, in the lungs, in all those areas, in your joints. Inflammation can happen everywhere for different reasons, and patients may be prone to this. So periodontal disease is a significant contributor to the total inflammatory burden on the body, and it adds to that inflammatory body, that's that burden on the body, and that can cause a greater response in other areas. So not only is it a problem locally, it can travel to other areas and increase the inflammatory burden in other areas. And that is the missing link. That's the pathway of action. So here we have a human with a bacterial situation in the oral cavity. You will see in a few moments, I will go over the individual areas, but you can see the cytokines are moving from the periodontal area to other parts and affecting the body and increasing the inflammatory response in other areas. So what are the different things that can happen to contribute? These are the pathways of action. First, you can have ulcerations of the pocket epithelium, and that promotes the risk of infection and distant sites and transient bacteremias. Second, the bacterial diffusion can release bioactive molecules like bacteria, bacterial products into the systemic circulation, and that can trigger an inflammatory response in another area and also add to circulating cytokines. Then we have the locally produced cytokines in the periodontal area that can act systemically to affect organ systems. So they don't stay just in the periodontal area. They will break down collagen. They will produce MMPs, which can break down collagen in the local area in the periodontal ligament, but they can also go to other areas and cause havoc with organ systems and other things. So they affect arteries and organs. They also induce the liver to produce C-reactive protein, which we know is a biomarker for inflammation. And that C-reactive protein can injure arteries and organs, leading to cardiovascular disease and strokes. We can look at this graphically again. So in the periodontal area, you can have breakdown of bacteremias caused because you have some breakdown because you've got ulcerations in the periodontal area and in the gingiva in the periodontal area. Then you can have bacteria and bacterial products going to another location and causing an inflammatory response there with release of cytokines and all the same things that happen in the periodontal ligament. Or you can have the cytokines of that of the periodontal area affecting organs like the brain, the heart, directly, the joints, the vascular system. And also the cytokines can cause C-reactive protein to directly affect the heart and the cardiovascular system. So all of this starts with local inflammation and can cause additional inflammation and contribute to the inflammatory burden all over the body. So we know that the relationship of periodontal disease to other chronic inflammatory diseases can be cardiovascular, it can be arthritis, it can be Alzheimer's, it can be diabetes, and it can be cancers. All of these and more, which I'll show you in just the next slide. So with the eyes, it can increase the possibility of macular degeneration, the heart blood vessel atherosclerosis. With the lungs, you can have asthma, COPD, liver, you can increase chronic hepatitis. With the digestive system, inflammatory bowel disease, the skin, acne, eczema, and you can see on the other side of it have Alzheimer's, multiple sclerosis, thyroiditis, diabetes, chronic kidney disease, some form of arthritis, autoimmune diseases. All of these things are inflammatory in the body. Anything that happens in the oral cavity, if it increases the inflammatory burden in the rest of the body, will contribute to these diseases. Everybody has the possibility of some area because they may be more prone. And if the oral cavity adds to that burden, it can make the patient more likely to be susceptible to these diseases. That's how the contribution works. So we know there's a link. How do we break this link? It involves working on the bacterial and the inflammatory pathways. But first, how do we measure it? What are we doing now? We're doing something, we're poking, just like with caries, we poke, at least in the past, we were poking to see if the patient had a sticky spot. We have a sticky spot. Oh, we've got a cavity. It's not the way to do it. And I think now we've got much better ways of detecting caries than before. But we have a lot of poking and seeing if it was sticky. And in inflammation in the oral cavity, we have bleeding on probing, and that's also sticking. And we know that dentists and hygienists have a different way of dealing with with a probe, and the angle is different. And it's not a very objective, systematic way of checking. That's all we have now. That's our gold standard. if we could find something a little bit better? So bleeding or probing is currently the only method we have for detecting ongoing oral inflammation. We know that under 10% of bleeding on probing, we have periodontal health. Over 10% is considered gingivitis, and then it could be way more than, and then we have much, much worse situation. We have more chronic inflammation, as I mentioned, and late stage chronic inflammation. So we'll have much higher amounts of bleeding on probing. How scientific is it? It's the unique predictive tests used by periodontists, by dentists, by hygienists. So we see under 10% is healthy, between 10 and 30% is considered localized, over 30% is generalized. It's a painful, time-consuming, and invasive way of dealing with understanding inflammation in the oral cavity. We have all these lovely little hooks, which are probes. Depending on how hard you press, depending on the angle, you're going to get a different reading in terms of pocket depth, but you could also elicit bleeding more easily, and if you poke a little harder. Now, there are several biomarkers that have been suggested. But they are later stage biomarkers. What if we could check early on to see before you can even see bleeding on probing, before you've got any clinical evidence of inflammation? Wouldn't that be something very special? And what if you could monitor how your treatment is doing by actually having an objective system instead of bleeding on probing, which is not objective and painful? So many are working to find a biomarker before periodontal disease is established. Because if we look at this graphic representation of periodontal disease, we are now looking at a reactive system because we're reacting to the clinical evidence. By the time you get clinical evidence, there's quite a bit of damage being done because now you have ulcerations and bleeding is happening. So we start off with a bacterial load, as I've explained. We've got an immune response, and we have subclinical tissue destruction. And the standard diagnosis is when that destruction takes place. Would it not be better to have it, as you see on the right, where you have the biomarkers, the periodontal diagnosis is early, and you have yourself predictive periodontology. So all of these are genetic biomarkers that are possible. And one that we have, so we have the genetic biomarkers, the microbial biomarkers, and other biomarkers. So we see on the left is we see MMP8s. And something that I'll be mentioning right now is something that is quite new and revolutionary. And the ideal biomarker, I actually have one more slide. Let me just tell you what the ideal biomarker is before I go over the one that seems to be ideal. It's objective and measurable. It's got clinical utility. It's accessible and non-invasive. It's fast. It's sensitive and specific to inflammation. And it can be validated and reliable. What doctors, as I mentioned, we are real doctors. But with the other real doctors, the physicians of the rest of the body, we are physicians of the oral cavity, but the physicians of the rest of the body use neutrophils. Remember, I mentioned those white blood cells, those early responders, neutrophils. The neutrophil count is a routine test included in a complete blood count ordered by physicians, and also in urinalysis. High levels of neutrophils in blood they may indicate an infection or inflammation in the body, such as a bacterial infection, viral infection, an autoimmune disorder. In some cases, high levels of neutrophils may be a normal response to a recent infection, just like what I mentioned earlier on the active acute response, which is healthy and beneficial. And we can see it. We can see it. Maybe it is a healthy response, or maybe it's chronic, and it needs to be investigated. So when you have high neutrophils, high oral neutrophils, it's a key sign of an active periodontal disease. Few neutrophils means things are happening, things are being improved, but a high neutrophil count is a key sign of active periodontal disease. As I mentioned before, just a little recap of neutrophils are the white blood cells. They are the first immune cells to respond to bacterial invasion. They're attracted to sites of infection and inflammation by chemical signals. These are the chemical attractants. On the site of infection, they release enzymes that break down bacterial cell walls. Excessive or prolonged neutrophil activity can lead to tissue damage and bone loss and can degrade the connective tissue and bone that supports the teeth. As I showed you, early, you have a low number of, there are neutrophils in the body all the time because they're there just in case something goes wrong. And then if you're in the acute healthy response, you might have just a slight increase in neutrophil level. But if it's a high level of neutrophils, we know that something is going on in the oral cavity and this has to be investigated. This is a screening device to know that there is something happening in the oral cavity that must be investigated. So here we have the neutrophil levels that reflect the severity of periodontal disease. If you have severe disease, there is a high level of neutrophils in the oral cavity that can be measured. If you have a moderate number of neutrophils, means that there is a moderate amount of periodontal disease. And in the control, there's no periodontal disease, there's a slight amount of periodontal disease. This was something that was checked in an experiment. And if you see on the left here, the patients that improved had a lower, and you saw the improvement clinically. Patients were examined clinically. The ones who improved also showed a very different amount of neutrophils in their bodies. On the left, there was improvement clinically as well as on the neutrophil level, and on the right, the initial and the reevaluation were the same. These patients did not improve. This is how you can actually test if what you're doing for your patient is working by measuring the neutrophil level. So oral neutrophils are the first responders. They correlate with periodontal disease level and they're quantifiable. How much better is this than bleeding on probing? So we need to evaluate oral inflammation, and now we have a much more objective, easier to do, point of care way of doing it. It's fast and accurate, very similar to what we had years ago when the blood pressure gauge was invented. Before that, people did not know that they knew that blood pressure was a problem, but they didn't know how to quantify it. That was a medical emergency, actually, because with the blood pressure monitoring, we can save lives. And physicians have that way of measuring and saving lives because they can predict when the patient is likely to have something wrong in their vascular system, and they can be controlled. Now we have a fast and accurate system as well for oral inflammation, which will, as we have shown, impacts systemic health of the patient. So here we have a way, just as the blood pressure gauge helped physicians, this is something we'll be able to help dentists. So the mechanism of action of this new oral neutrophil test is measuring. It measures. So oral neutrophils have been able to be measured in the lab forever, but that's a lot more time consuming. You have to send it out to the lab. It's a much better idea to have something point of care at Sherasonic. When you measure neutrophils in the lab, you actually measure the neutrophils. At the chair, what is being measured is the color change, which happens with the enzyme level. The neutrophils are releasing these enzymes. The higher the number of neutrophils, the stronger the enzyme level and the stronger the color. So more neutrophils, greater enzyme activity, higher, stronger color. And that's what it is measuring. So the patient has to just rinse and spit and dip the strip. So when they rinse and spit, they spit into a cup, a strip is put into the cup, and the color is red after a minute. There's no training needed. It can be done by the dentist, the hygienist, or the dental assistant, or even at some point, possibly by the patient. So it was a test. This was tested. There was a two double-blinded study, multi-center with greater than 500 patients, and it showed high sensitivity and specificity to neutrophil levels that are measured at the lab. So this new salivary rinse test is objective and measurable. It is very useful clinically, accessible, and non-invasive. It's fast, it's sensitive, and reliable. Bleeding on probing may be most of those as well, but it's uncomfortable. It's not as objective, and it's very different. Not every it's done most of the time. But it's always done at the first visit. But is it done always at every recall? In some offices, yes. In some jurisdictions, it's mandated to be done at every recall, and some not. This is something that can be done at every recall very easily to see if treatment is working, if the patient is responding. So they are the ideal biomarker of oral inflammation. Patients like to see their results. This engages them. This is something that's a fast and simple test to measure oral neutrophils, and this is something that is needed chairside. So the patient, when you're poking at their gums, they don't know what's going on. All they know is they're in pain and they're uncomfortable, and you're going around with a very sharp instrument and poking. With this, you're showing them something that's objective and something that they can see and they can relate to much more easily. And they can relate to this because they're used to different systems of the biomarkers. They're told by their physicians about their results, and this is a scientific, objective result, just as the real doctors do. And we are real doctors. So basically, the test is a rapid 30-second rinse test that measures oral inflammation. It's quick and measurable, a quick chairside test. Patient, as I said, just rinses their mouth for 10 seconds. Then they spit into a cup. Then the indicator is placed into the cup, and it's there for 1 minute. And the colors show as indicated here. Negative is let's say an off-white, low is a little bit of a purple color, moderate is stronger, and high is a very strong purple color. Here we have different situations and what they show up clinically. Healthy patient, no bleeding on probing. Patient has beautiful gums, no gingivitis. And this is very easily shown with the oral neutrophil test. And you are also going to see whether something's going on subclinically. The oral neutrophil test will pick up things subclinically as well. When you finally have bleeding on probing, that's when things have gone haywire for quite a while. So when a patient has a moderate, this is actually more than moderate. This is quite advanced. So this is 40% bleeding on probing, and you have a stronger color. And so you know that the patient has something is going on, and you can see it clinically as well. But with the neutrophil test, you can actually see it earlier as well, like I showed you on the first. Okay, so what about when it's severe? Periodontitis patient, 70% bleeding on probing. So you see much stronger color. So with the neutrophil levels, they can be used to screen for periodontal disease associated with inflammation. Of course, we can see things once it's very far gone. We can see it even without doing bleeding on probing. You can even look at the patient's mouth and know that they have severe periodontitis and they have severe inflammation, and that could be impacting. But earlier on, we can't. Bleeding on probating is not as accurate. It is not as sensitive. So it's not something that can be used early on. And can it be used to check if the patient is responding to treatment? No, bleeding on probating is not as exact. Whereas here you can see and monitor how the patient is doing. So this new oral inflammation test is a non-invasive chairside objective test that can be used by dental professionals. It's simple, rapid, visual results are easy to understand. It accurately identifies active oral inflammation and the resulting inflammatory load that can impact the rest of the body and cause problems in other areas. The results can be used to formulate the treatment plan as well as to monitor the efficacy of treatment. And very importantly, the patient is fully engaged with the process and more confident with the treatment plan. So we have a medical solution for a dental problem. Just as the blood pressure gauge helped physicians improve the life of their patients by giving them something to help them early on so that they did not develop more cardiovascular disease. Now we have something that can help us know when our patients have oral inflammation and monitor how our treatment is doing. We have the means to measure the disease, to go from oral disease to systemic disease, and now we have a way of breaking the link. So we, as real doctors of the oral cavity, will be able in the future. This has not been launched yet, but it is soon to be launched. We will have a way of being able to actually measure the link quantifiably, the way physicians measure neutrophils in the blood and are able to know when the patient has something wrong. We can do it early on. Thank you very much.